Hello, and welcome to the Johns Hopkins University School of Medicine CME course entitled Clinical Portal: Practical Considerations for the Use of Surgical Scaffolds in Soft Tissue Reconstruction, sponsored by a grant from Allergan. In this module, we'll provide a basic framework for the course, a scaffold for the scaffolds, if you will. My name is Michelle Manahan. I'm faculty in plastic and reconstructive surgery at Johns Hopkins Hospital. I'm also the CME course director and your guide for this introduction. Thank you in advance for your attendance. In this module, we'll begin by defining scaffolds. We'll enrich this definition with some clinical applications, and we'll delve into the scaffolding types and their characteristics. We'll also highlight some controversies. Please remember, this module and the others are designed to summarize and merge the academic state-of-the-art with clinical expertise at this point in time. We know that the art and practice of surgery is constantly changing, and the learner should be ready to adapt this knowledge as needed to his or her environment and time. It is hoped that this introduction will spark your interest in further exploration of our other modules, which include some very interesting and informative case examples, including pictures, diagrams, and clinical videos. This module serves as an introduction to guide your further learning, but is not an exhaustive review. What is a scaffold? Even those of us in medicine are probably most used to scaffolds in daily life, as an aid to building construction. Most basically, a scaffold is a mechanical construct to provide support. In surgery, scaffolds do the same thing. We use scaffolds to restore, repair, rebuild, and support tissues that are damaged, weakened, or absent. Surgical scaffolds can really be employed anywhere in the body where they're needed. Common areas include the head and neck, breast, abdomen, and even the extremities. Patients with facial weakness, for example, encounter devastating and very visible sequelae of their disease processes. Scaffolds can be used in a subcutaneous plane and anchored to bone or other strong tissue of the facial periphery. The scaffold can then be stretched to the areas of droop, such as the nasolabial fold or the eyelid, and tightened to mask the asymmetries. Breast reconstruction is an extremely common area of scaffold use, particularly following mastectomy. The nature of a mastectomy leaves the breast architecture with the chest wall structures and the overlying skin, with at most a thin layer of non-supportive subcutaneous fat. Yet the volume necessary for reconstruction adds weight that the skin alone may be insufficient to support, and this is why scaffolds are employed. Scaffolds can be used either alone and anchored to the chest wall structures, or in combination with the native chest wall structures to support the volume and weight of the breast reconstruction on the chest in an appropriate shape and position. Surgery on the native breast may also benefit from scaffold use. Native breasts may become ptotic over time and require support of the atretic native tissues to rejuvenate the breast shape and the appearance. We have some very nice clinical examples for you of breast surgery using scaffolds, so please do review our other modules. Scaffolds may play similar roles really anywhere in the body where tissue has become lax. We know that two major contributors to droopy skin are the effects of gravity over time, or aging, and weight loss. And scaffolds are well known in body contouring, even the extremities. They are probably particularly helpful in patients with previously damaged skin due to stretch marks, age, photo injury, where elasticity that we hope will contribute to the long-lasting effects of our repairs is unreliable. Along these lines, the weight loss population is at higher risk for poor nutrition, and these patients may really benefit from additional support during surgery. Of course, the flip side is that the introduction of new material, like a scaffold, into the surgical site increases the burden for wound healing. So really, nutritional optimization rather than substituting a crutch for poor nutrition, is the answer in preoperative preparation. Another very common area of scaffolding use is in the abdomen. Hernias occur frequently, and they often recur even after surgical correction, because many times the same factors that led to a hernia developing in the first place still remains after the correction. Things like chronic cough, intra-abdominal obesity, and poor quality tissues usually aren't fixed with surgery. Scaffolds can help patients who are at high risk for hernia recurrence, and they can allow for abdominal wall reconstruction in patients who would otherwise be inoperable due to lack of adequate native tissues. Patients may also benefit from abdominal wall strengthening with scaffolds even without a true hernia, because often the muscle wall derangement without a true hole or hernia can be as uncomfortable and as unsightly as a true hernia. Patients, for example, with rectus diastasis after pregnancy, patients with abdominal wall weakness due to denervation from prior surgeries, and those who just have poor abdominal muscular strength may all be scaffold candidates. We also see scaffolding used to reinforce the abdominal wall at the time of primary abdominal wall surgery to attempt to prevent future problems. We have some excellent clinical illustrations in our modules by Dr. Becker and Dr. Verhalen with regard to the abdominal wall. I think it's about time we started talking about specific surgical scaffold types, don't you? So in the broadest sense of the word, again, surgical scaffolds can be just sutures that pull together autologous tissue and provide additional support. Surgical scaffolds can also be autologous tissue introduced from another region into an area of weakness. But scaffold types, in the common usage, usually refer to external materials, such as acellular dermal matrices, and we know that these can be derived from non-human animal sources as well as from humans, or prosthetic mesh. These can be resorbable synthetic mesh, permanent synthetic mesh, or bioresorbable proteins like silk. We're just about ready to break these types of surgical scaffolds down into their struts and joints, to keep our building analogy going, and really get to know them. Before we do, though, a warning is in order. As the ancient Romans would say, caveat emptor, buyer beware. There are a wealth of scaffolds available for use. It's my opinion that this probably means that no one scaffold brand or one scaffold type is the perfect choice for every opportunity. The surgeon considering a scaffold should think about all of the following properties, carefully weighing the advantages and disadvantages of each scaffold in each area prior to selecting a scaffold for a particular case. It's important to note also that sometimes these characteristics become clearer only with more widespread use over longer times. So also consider the changing history and changing body of literature for each type of scaffold. Does the scaffold revascularize itself? Does it promote somehow revascularization in the surrounding tissue? What's the timing for this? And to what extent does the revascularization occur? Does the scaffold promote inflammation? What cell types are involved in this inflammation? Are granulomata formed? What's the strength of the scaffold, up front at the time of the placement in the patient and over time? Is this a load-sharing strength or a load-bearing strength? Is the scaffold itself resorbed? Does tissue grow into the scaffold? What's the timing and the speed of this? What happens while the body's waiting for the resorption or tissue ingrowth? Does the scaffold promote or allow collagen formation? What type of collagen is formed? What's the orientation of the collagen? Again, what's the timing for the collagen formation? What does the scaffold do for scarring? Is there chronic inflammation associated with the scaffold? Is there fibrous encapsulation of the scaffold? And what's the scaffold's association with infections, seromas, extrusion, erosion, and other complications. Does it promote these? How does it act when that complication might occur in the vicinity and maybe not even related to the scaffold? Autologous tissue can serve as a scaffold. This can be harvested and transferred either as a flap with its own blood supply or as a graft, which requires blood vessel ingrowth from the recipient site. Flaps may employ actual fascia for scaffolding strength or may substitute skin and its dermis as the strength layer. Take, for example, perineal reconstruction after an APR for rectal cancer. To reconstruct the pelvic floor and prevent perineal herniation of the abdominal contents, a surgeon might choose either a TRAM, transverse rectus abdominis myocutaneous flap, or a deep inferior epigastric perforator flap. Both can be harvested from the abdomen, but the TRAM includes the muscle fascia, while the DIEP transfers only subcutaneous fat and dermis. Flaps and grafts may be harvested from similar sites, for example the thigh. The fascia lata graft may be harvested from the thigh, as can an anterolateral thigh flap, which can be harvested with or without fascia, with skin and its dermis for strength as well. Autologous tissue requires a donor site, and with the requirement for a donor site comes a risk of donor site deformity and decreased functionality at the donor site. Additionally, autologous tissue is a limited resource. There are only so many areas on the body that can donate tissue to another area, and there are only so many times that one might harvest tissue from a certain area. Autologous tissue may fail. It may fail mechanically as a scaffold, but it may also fail because of lack of survival, because of inadequate blood supply. Autologous tissue discussions with patients may lead to questions like, will I have a scar? Or 12 hours of surgery, that's a long time. Or you're taking tissue from where? So often the discussion about risks and benefits can be complex. On the other hand, autologous tissue can be very beneficial for patients who don't want any foreign bodies or who want to use excess tissue in another area, say the infraumbilical abdominal roll, to reconstruct deficits in other places. This can be seen as a silver lining to the need for reconstruction. Autologous tissue is natural, and as such, it tends to be more resistant to complications in the wound, such as wound healing problems or infections. As I've already mentioned, a common material for surgical scaffolds is an acellular dermal matrix. This means that the dermal component of the skin has its cells removed, leaving behind the collagen matrix. There are many types and many brands of ADMs, and these often differ by source material, such as bovine, cow, porcine, pig, or human. ADMs also differ by processing mechanism, and these details are often proprietary. Processing methods, though, can impact the size of the material that's available, its shelf life, as well as its cost. Different ADMs retain their strength more robustly, while others stretch over time. As you're reviewing the other modules in this course, you'll hear a lot more about this. But just as a preview, for example, staged breast reconstruction with the use of a tissue expander benefits from the ability of an ADM material to stretch over time. On the other hand, abdominal wall reconstruction, particularly with the use of an ADM as an interposition graft to fill an otherwise unsupported defect of the abdominal wall, benefits from more rigid maintenance of the scaffold surface area over time. Properties of the ADM may also contribute to the complication profile. Because an acellular dermal matrix requires blood vessel ingrowth to become incorporated into tissue, lack of blood vessel ingrowth can promote a potential space between the native tissue and the ADM. This could promote seromas. The seromas, being a nutrient-rich fluid, could then promote infection. Fluid accumulation in the area could promote wound breakdown. There could also be an inflammatory response to the acellular dermal matrix itself or to some of the components added during processing. This could promote inflammation and scarring and fibrosis, which could affect both the strength of the matrix, the strength of the tissue around it, and the appearance of the tissue around it and overlying it. Different ADMs may be handled differently in the operating room. For example, some acellular dermal matrices may be ready for use in surgery immediately after being removed from their packaging. Others may require rinsing or soaking. Acellular dermal matrices may also be handled differently in the operation itself. Some may be thicker, less pliable, less able to be molded to the space, and less able to be sutured, while some acellular matrices may be very pliable and very amenable to suture penetration. The next slide is a busy one. It's a table with the names and properties of some of the ADMs. I really want you to have an opportunity to review this for yourself, so please take your time on the slide. Next, I'd like to discuss some clinically relevant pearls regarding patient and procedure selection, intraoperative techniques that may impact outcomes, and post-operative monitoring and complication management. Patient selection pearl number 1. ADM does not require time to harvest, so it can be a good time saver in sick patients in whom you may want to minimize anesthesia time. Patient selection pearl number 2. ADM does not require a donor site, so it can be a good option if donor sites are unavailable. It's debatable, though, whether it's a better or worse idea in patients who are sick or who are poor wound healers, where you may want to avoid a donor site. By adding an autologous tissue donor site in these patients, this requires an additional healing burden. But ADM does not heal itself. ADM requires that the surrounding tissue be of adequate quality to support it. Take, for example, an irradiated chest wall with thin, fibrotic skin and an underlying implant-based breast reconstruction ready to extrude. Thickening the soft tissue over the implant is the goal, and most surgeons would advocate for autologous tissue alone or over top of the implant, rather than simply opening the skin and adding ADM between the compromised skin and the implant. Procedure selection pearl number 1. ADM does not heal itself and does not fill dead space. Remember the APR example from earlier in the talk with the perineal defect? Let's up the ante. Let's make it a wide resection for recurrent disease with a history of perineal radiation treatment. Spanning a large three-dimensional space with a thin sling of ADM is likely doomed to fail. The dead space may promote seromas, infection, and wound breakdown, and the ADM is likely not to revascularize, since it's likely not approximated to viable tissue to support blood vessel ingrowth. Procedure selection pearl number 2. ADM does not fight infection until it's revascularized, so placement of the ADM in a grossly infected wound means that the wound is likely to lose its ADM. Regarding intraoperative technical pearls, number 1, make sure you properly process the ADM. Do not rely on the scrub tech's innate knowledge of the proper processing technique, since ADMs differ from product to product with regard to recommendations for processing. Number 2, consider perforating and/or draining the ADM based on the clinical situation. Imagine a beautiful primary repair of an abdominal wall defect that was placed over a wide underlay of ADM measuring, say, 10 by 10 centimeters, with no drain in between. Imagine the body day by day sending a little bit more fluid into that potential space. Imagine that fluid gradually seeping through the primary repair and breaking it down before the scar can mature. Imagine that strong contractile abdominal wall musculature edging back away from the midline. Fast forward a few months, when the patient returns to clinic with a symptomatic bulge and a CT consistent with midline atretic tissue and retracted rectus muscle with loss of domain. Consider draining or perforating the ADM if clinically warranted. With regard to postoperative monitoring pearls, number 1, anticipate complications. Counsel and watch for them. Breast patients should know to seek medical attention for a water balloon type feel under the skin and for red, hot, tender, swollen breast skin, for example. Pearl number 2, give a wound time to heal if you can. Some ADMs start to revascularize very quickly. In the abdomen, for example, the skin may be compromised, but the exposed ADM may be revascularizing from the deeper tissue. Number 3, don't over-debride. It's not a plastic mesh. Most of the time, the debridement can be limited to an area of obvious complication and not require recreation of the premorbid defect. As with most things in medicine, controversies abound regarding when to use ADM, when not to use ADM, and when to substitute something else for ADM, or to substitute ADM for something else. So let's look at the controversies in the breast. This can be breast reconstruction or revision after cosmetic implants, because ADM is commonly considered in these situations. So with regard to breast reconstruction, ADM can be used at the time of tissue expander placement. It can be used to completely wrap the expander and place the expander in a subcutaneous plane, or it can be used in conjunction with the pectoralis muscle for partial submuscular coverage, or it can be excluded and the expander can be placed in a totally submuscular plane. When a tissue expander is exchanged for an implant, or there is a revision of a cosmetic augmentation gone wrong, the ADM can be used to support and redefine the margins of the breast, smoothing irregularities in contours medially, laterally, and superiorly, and increasing the crispness of the inframammary fold inferiorly. It can also thicken the tissue, decreasing potential visible rippling and wrinkling of an implant, and ADM can potentially reduce capsular contracture. Use of ADM, particularly in a tissue expander case, can increase the amount of intraoperative expansion that's performed and therefore decrease the inconvenience to a patient in terms of the number of times that they need to return to clinic for expansion. However, as we have mentioned in the previous slides, ADM can be associated with seromas and infections. An introduction of a non-vascularized construct between poorly vascularized post-mastectomy skin and better vascularized tissue may promote mastectomy flap necrosis. Let's move now to talk about another type of surgical scaffold, prosthetic mesh. As we've seen with autologous tissue, as well as ADMs, there is a lot of variability with regard to prosthetic mesh. There are many areas of variability, and one of them is the material of which the prosthetic mesh is made. This can translate into variable resorption. Some mesh is designed to resorb as early as 2 weeks after it's placed. Other mesh resorbs over multiple years after placement, and some mesh is permanent. There are, of course, and unfortunately, risks associated with the use of prosthetic mesh. Some of these risks relate directly to the fact that it's a foreign body. It's a foreign body that remains a foreign body. So it is prone to break down with failure at the suture line, where sutures may tear through or it may separate from the surrounding autologous tissue. It's also prone to fracture and failure due to that mechanism. Similarly, this prosthetic mesh may be exposed to the external environment if there's a wound healing complication that occurs over top. Unlike an ADM, and unlike autologous tissue, this prosthetic mesh will remain an unchanged prosthetic mesh even when exposed to the outside world. This means that there is a potential for contamination and infection of the prostheses, which then would require removal. Unfortunately, the removal may require recreation of the entire premorbid defect. Some types of prosthetic mesh, if exposed to the bowel, may over time wear at the native tissue of the bowel and cause erosion with bowel injury. Up next is another busy slide. It's another table, this time listing the names and properties of some of the prosthetic meshes available for use. Because I again want you to have the opportunity to review this for yourself, please take your time before advancing past the table. Let's talk now about clinical pearls for mesh use. Preoperative planning for mesh, pearl number 1. Talk to your co-surgeons. For example, when considering abdominal wall reconstruction at the time of hernia takedown and lysis of adhesions by your general surgery colleagues, have a good conversation about expectations. How bad does the CT look? What's the likelihood of bowel injury? How much undermining and therefore vascular interruption is expected prior to reconstruction? Preoperative pearl number 2. Come back to fight another day. If facing a situation where the persistent strength of a prosthetic mesh is felt to be beneficial, but the current environment is suboptimal, say there's an enterocutaneous fistula preoperatively or intraoperative spillage of bowel contents, or poor quality skin flaps, delay. Plan a return to the operating room for introduction of a strength layer of mesh after vascular regrowth and the contamination is cleaned up, but before loss of abdominal domain. Intraoperative mesh pearl number 1. Choose the correct tools. Consider the properties of the mesh and the job you might be asking it to do. Intraoperative mesh pearl number 2. Careful does it. Introduction of a bolster material is not a substitute for careful technique. Close approximations of the margins of the mesh to the surrounding tissue is really necessary to avoid knuckles of bowel from incarcerating. This insetting should be as careful as a primary repair of the abdominal wall. Sometimes parachute sutures are necessary to allow careful approximation in this fashion. Additionally, quilting of an onlay mesh is helpful to promote tissue through growth. Postoperative mesh pearl number 1. Don't open the wound too early. Let the drains do their jobs. If a slightly irritated staple entry into the skin is misjudged to be a harbinger of a wound infection and the incision is opened, an onlay mesh will be exposed. If this is done prior to tissue adherence throughout the undermined planes, a 1 centimeter wound at the skin can be an entry portal to an entire cavern of exposed mesh, the surface area of the whole anterior abdominal wall. Let's take the abdomen as a clinical area to evaluate some of the controversies that still are associated with the use of prosthetic mesh when looking at the literature. Some data appears to demonstrate that prosthetic mesh, when used for hernia repair, is associated with both lower recurrence rates as well as lower costs when compared to ADM. However, some data shows that ADM versus prosthetic mesh actually have comparable rates of surgical site infections, seromas, explants, 90-day readmissions, and recurrences. And then some data actually demonstrates that mesh is associated with higher hernia recurrence rates, surgical site infections, and reoperation rates when compared to ADM. So it's pretty apparent that there's no unifying theme regarding the benefits versus the disadvantages of the use of mesh in the abdomen. Now, there are a lot of confounders that may contribute to some of this data controversy. There are various ways to combine different techniques. These techniques can also be compared to plain sutures or suturing with autologous tissue, either alone or in combination with use of prosthetic mesh or ADM. And the execution of a particular technique may vary from study to study. And with these studies, there is definitely a risk for selection bias. We'll move now to the discussion of the final type of scaffolding for this module. This is a silk mesh, and right now there's really only one commercially available brand, and this is called Siri. This is a sterile, purified, multi-filament knitted silk mesh, processed differently than silk sutures. We've talked in previous slides about the need to understand the ways to handle the material intraoperatively, and Siri is a strong, pliable, yet cuttable material. We know that all of the materials, all of the surgical scaffolds that we've discussed today, work as a foreign body when initially placed at the time of surgery. This silk mesh transfers its load-bearing responsibility to the native tissue over time as it demonstrates long-term bioresorbability. Additionally, the silk mesh demonstrates collagen formation and organization, neovascularity, and inflammation like wound healing. This is important when the operator may be comparing use of the silk mesh to the prosthetic meshes as well as the acellular dermal matrices. When compared to the other types of surgical scaffolds that we've already discussed today, autologous tissues, acellular dermal matrices, and prosthetic meshes, Siri silk mesh is a newer product. It has less literature associated with it and a smaller body of clinical experience from which to draw. There do exist, however, case reports and case series to help a surgeon deciding when to use a silk mesh in the preoperative planning. It's important to note, however, that in addition to reports and series reporting the uses and successes of the silk mesh, there have been some reports of infection associated with dense fibrosis that makes a return to the operating room to treat a complication very difficult, and this must be kept in mind. With that, we'll conclude our introductory didactic module for the CME course Clinical Portal, Practical Considerations for the Use of Surgical Scaffolds in Soft Tissue Reconstruction. I hope you'll feel that we've met our goals of defining scaffolds, describing scaffold use in different anatomical areas, explaining different scaffold types available for use, and highlighting some of the controversies associated with surgical scaffolds. I'd strongly encourage you to continue on to our clinical modules. There's some excellent diagrams, photographs, videos, and clinical pearls that will be useful for all surgeons. Thank you very, very much for your time and your attention today. The next slide will show the references. Please feel free to review that as you need.